also for giving me this opportunity. So we are going to talk about stellate ganglion block. Slide please. The blocks are not, as you are seeing in this picture, these are not these blocks. We are basically talking about the pain intervention on the stellate ganglion, and this will provide interruption of the sympathetic efferent fibers to the upper extremity, head and neck. The few important anatomies, there is a longus 𝐒𝐻𝐵𝐢 muscle, then this is the C6 transfer process, so it's a segment anterior tubercle, C7 and T1. This is common carotid artery, then subclavian, this is vertebral, and this is the superior cervical ganglion, middle and inferior cervical ganglion. So stellate ganglion lies here. So its utility is to determine if the pain is sympathetically mediated or not. What happens in sympathetic mediated pain? That due to abnormal connection between sympathetic and sensory nervous system, there is pain. We come to know if there is significant pain relief after block, it means there is significant component of sympathetic mediated pain, and we, after giving block, we can determine if neurolysis or surgical sympathectomy could be beneficial. So the sympathetic fibers for the head, neck and heart and upper limb arise from the thoracic spinal cord T1 to T8. These ascend through the sympathetic chain and synapses in the superior, middle and inferior cervical ganglion, as you can see here. In 80% of population, the inferior cervical ganglion is fused with the first thoracic ganglion, forming the cervicothoracic ganglion or the stellate ganglion. So, and nearby this is the vertebral artery, which goes anterior to the C7 tubercle, but goes in the transverse foramen from C6 upwards. So this ganglion measures 2.5 centimeter long, 1 centimeter wide and half centimeter thick. This light is the level of the C7 and T1 anterior to the transverse process of C7 and first rib and longus 𝐒𝐻𝐵𝐢 muscle. This is the longus 𝐒𝐻𝐵𝐢 muscle. This lies anterior to these muscles, and the borders are the longus 𝐒𝐻𝐵𝐢 medially, then the scaly laterally, then subclavian artery, then vertebral artery posteriorly, the transverse processes posteriorly, the carotid artery anteriorly, and the nearby structures. This is the phrenic nerve, the vagus nerve, the recurrent nerve, and the brachial plexus. So this is a very useful block, and there are so many indications for this block, starting from the complex regional pain syndrome of head and upper limbs, the peripheral vascular disease, the upper extremity embolism, the post-herpetic neuralgia, the chronic post-surgical pain, hyperhidrosis, Raynaud's disease, scleroderma, orofacial pain, phantom limb pain, the atypical chest pain, cluster or a vascular headache, post-traumatic stress disorder, the Meniere's syndrome, intractable angina, and the refractory cardiac arrhythmias. But there are still few contraindications. The one is recent MI, the anticoagulant patient or coagulopathy, the contralateral diaphragmatic paralysis, because then you may block the same side ipsilateral phrenic nerve also, the cardiac conduction block, the contralateral pneumothorax, because you may puncture the pleura while performing this block. Then glaucoma is one of the contraindications, and if patient is having severe emphysema. So there are few techniques. There are 4 techniques basically. We will be talking about the 3. One is surface landmark technique, the fluoroscopic technique, the USC guided or the CT guided. So as we have discussed that the ganglion lies in front of C7 and T1, but most commonly this block is performed in front of the C6. So why we need to choose C6 for the landmark? Because then the vertebral artery goes posteriorly in the transverse foramen and through that ascent upwards. So, but most likely this happens considered more safer for the landmark targets. So in this view, you can see this is the trachea, then esophagus, this is thyroid, this is the C6 transverse process, the 𝐒𝐻 tubercle, the vertebral artery posteriorly in the transverse foramen, then AgVa and few things. So what is the position? Patient should with then a carotid cartilage is palpated to find the C6 level. We then move laterally and downwards to feel the C6 𝐒𝐻 tubercle with the finger compressed. Style percussion, skin and subcu tissue pressed against tubercle. The needle advance. Then once we hit the bone, then we withdraw a little bit 2 mm, so that we are just out of the longus colli muscle, but still beneath fascia. After 1 mm test dose is given, after negative expression of, look, we need to check for the negative expression of 3 things. It is very important for the blood. You may be in the lungs, you may be in the CSF space, or you may be in the one of the arteries. Then you can give the local bupivacaine or ropivacaine into 10 ml, and patient to be assessed at least 30 minutes post block. Then the same procedure can be done the fluoroscopic guided. The landmark and patient posting is same as for the surface landmark. What is the advantage? That bony delineation is better than, and the procedure can be performed with fluoroscopy either on C6 or on the C7. Few like to perform on C7 and few like to perform on C6 because they think that C6 is still safe. So when we are giving local, what it will do, if we injected a right place, the local or your neurolytic agent will trickle down and it will block the stellate ganglion. So oblique fluoroscopy technique is most commonly used, and the contrast is given to confirm the needle placement. If there is proper facial pain, you are in the exact position, the local will spread and contrast will spread both up and down side. If you are in the muscular, so next slide. So this is the honeycomb appearance. If you are given a block just beneath the prevertebral fascia and anterior to longus colli, but you may see this kind of appearance, stellate appearance, if you are in the longus colli muscles, and then your block may not be that effective. Then you can go to the USC guided. So this is how you give the USC guided block. The carotid sheath and stellate muscle to be retracted laterally with transducer. Presses applied with the linear transducer probe. The needle is inserted directly toward the 𝐒𝐻 tubercle. Then it's withdrawn again, and after negative expression, LA can be injected and spread to be visualized with the ultrasound. So again, this is trachea, this is esophagus, the longus colli muscle, prevertebral fascia, this is thyroid, carotid, and all. So why this route is preferred? Why ultrasound is preferred? Because in either you are giving fluoroscopic guided or surface landmark, you are going perpendicular to the skin. But as you can see here, this is cricoid, and just near this there is esophagus. So sometimes you may puncture through esophagus because it is not necessary. In up to 40% of patient, esophagus may be just lateral to the trachea instead of being behind the trachea. So it is better to use ultrasound so that you may avoid puncturing through the esophagus, or immediately there may be inferior thyroid artery. So esophagus or inferior thyroid artery may be damaged with the PS techniques. So this is sonotomy. This is sternocleidomastoid muscle. This is common carotid, AgVa, the longus capitis, longus colli muscle. This is a transverse process, and just behind, in front of longus colli muscle and behind the common carotid artery, there is sympathetic chain. This is our target. So and this is the needle entering, and this is spread of our local anesthetic. This is longus colli muscle. So the C7 anterior approach can also be used. This is nearly identical to the C6 approach. So what advantage? The needle is closer. Local agent may with more reliable and consistent blockade, and it may be useful if your previous C6 block the C6 level has been failed. And for this you require either fluoroscopic or the USG guided approach, because surface landmark you can't use here because The tubercle is very small and you may not feel it. So what may be the various complications? The complications are numerous, so this to be done very meticulously. It may be from vesicular puncture of the common carotid or internal jugular, internal thyroid artery or vertebral artery. The needle puncture may, few nerve roots may be damaged like vagus, recurrent brachial plexus or the phrenic. There may be pneumothorax because you can see the dome of the lung just nearby. This is the stellate ganglion and just lungs is just nearby. So there may be thyroid injury, the esophagus or tracer puncture may be there, the transient Horner syndrome, which we many times we see. Then intravascular injection may lead to the generalized seizure and then infection, and there may be paratracheal hematoma. A few references for this. Thank you.
Thank you very much. Any question?